Relapsed Multiple Myeloma, moderated by Dr. James Chim from Queen Mary Hospital, University of Hong Kong, and Dr. Virasak Nawarawong from Chiang Mai University.
I start with the first step. Good morning. Welcome to the multiple myeloma session on relapsed multiple myeloma. It's great honor to introduce our first speaker, which is from the previous session, Dr. Elizabeth Manasan. She is from Department of Lymphoma Myeloma, Division of Cancer Medicine, University of Texas, MD Anderson Cancer Center. She will talk about defining relapse, biochemical versus symptomatic, when to increase the dose, when to switch therapy. Please welcome Dr. Manasan, please.
You want me to go first?
Yes,
She's coming in?
Oh, she's coming.
Okay, so this lecture is about the definition of relapse and when we usually start treatment at relapse, because after this there are about a few presentations talking about what medications to choose for relapse, and then there are some focus points on proteasome inhibitors and then immunotherapy and cell therapy and so on. So this is really just about what we understand for the definition of relapse and when we usually do initiate treatment. As you know, and I've explained earlier, monoclonal gammopathy of unknown significance and smoldering myeloma usually precede multiple myeloma. And usually when the patient does have myeloma that requires treatment, and we've discussed today what are the definitions for that and what are the criteria for that, always using common sense, then we initiate treatment. And unfortunately, after treatment, multiple myeloma usually follows this relapsing and remission pattern that we see here. And usually the relapses each time last or are more difficult to treat, and sometimes also the remission phases last a little bit less. And when the myeloma is then refractory, the prognosis for these patients is usually very poor. You may have seen this slide before. This is just a treatment slide to see how far we've come with treatment for multiple myeloma. It really has only been about 10-15 years since we started using proteasome inhibitors, which was a major breakthrough in the treatment for myeloma. You can see also here the rates of very good partial response throughout the different treatments as they have been reported in clinical trials. As I mentioned, the duration of the response decreases as the number of treatments received increases, which is also linked to poor prognosis. So how do we define clinical relapse? So there are very clear definitions by the International Myeloma Working Group criteria about this. So usually we need, in patients that have an M protein in the blood, an absolute increase of 0.5 grams per deciliter, which we usually need all these assessments that we're talking about. We need them in 2 different time points, so they have to be confirmed. We also need an absolute increase if the patient has Benz-Jones. We can use the urine M protein, or you can use also the kappa and lambda light chain levels. We're using the M protein. There has to be an absolute increase of 200 milligrams of Benz-Jones in 24 hours. if we're using the difference in the kappa and lambda levels, or lambda and kappa, depending on what the patient's protein is, then the ratio between the abnormal and the absolute change has to be more than 10 milligrams per deciliter. If the patient does not have measurable M protein levels and we're looking at just bone marrow plasma cells, the increase has to be at least of 10%. The patient may also have just extramedullary myeloma. If they have new bone or soft tissue lesions, that's also an indication for relapse. And if they have hypercalcemia that is due to the myeloma, then we would also consider these an indication for treatment and relapse. The definition of refractory myeloma is a disease that is not responsive while on therapy or that progresses within 60 days of the last therapy. And this is what's used as refractory when we talk about refractory myeloma, especially in clinical trials. We also can divide the relapse between asymptomatic and symptomatic. So biochemical relapse, or an early biochemical relapse, is a term we use for patients who have an increase in their myeloma paraprotein or light chains, but do not have any symptoms or organ compromise. These patients oftentimes can be observed closely without treatment. However, early intervention may also be warranted, and we'll see in what situations we may consider to intervene in these patients. Symptomatic relapse occurs in patients that have new symptoms or organ compromise that can be attributing to the underlying relapsed myeloma. And in these patients, treatment should be instituted promptly. The goal of this treatment is to relieve the disease symptoms. So what are the indications for treatment and relapse? For clinical or symptomatic relapse, this is very similar to what we have for diagnosis for the newly diagnosed myeloma. So if the patient has new soft tissue plasmacytomas or bone lesions, if there is an increase in the size of existing plasmacytomas or lesions, if there is hypercalcemia, if there is anemia to a certain degree, if there is a rise in serum creatinine that is due to the myeloma, or if there is hyperviscosity. When there is significant biochemical or asymptomatic relapse in patients without a clinical relapse, we may also consider the initiation of therapy. For example, if there is a very consistent increase in the M component in the blood or in the urine. For example, here there's a measure that if it's more than 0.5 grams per deciliter, separated by at least 1 or 2 months, if this is doubling very quickly, then this could be a sign that we need to start treatment because this patient may develop symptomatic myeloma from relapsed in the near future. Also, if there are 2 consecutive measurements, if the absolute levels of the M protein go by 1 gram per deciliter or 10 grams per liter, if there's an increase in the M protein by 500 milligrams in 24 hours, or if there is an increase of 25% of the light chains or more than 20 milligrams per deciliter with an abnormal ratio. So this could be all indications that we need to start treatment. So these are some measures that you can use in your patients in the clinic. There are also some treatment guidelines that have been published for the choice of treatment at relapse. And I think that our later speakers might go into this with more detail, but I'm just going to mention a few things that are a little bit of common sense. So the first thing is, has the patient had a stem cell transplant? So if they had not had a stem cell transplant, you could treat and transplant them. And then you also have to consider what has been, if they have had a transplant, what has been the first induction treatment that they got before the transplant. And then you also consider, have they gotten any novel agent? Usually that's bortezomib, lenalidomide, carfilzomib, and so on. If they have never gotten a frontline novel agent, then usually they recommend bortezomib or IMiD-based therapies. If they have had bortezomib and IMiD-based therapies, then if there has been a very long remission, then you could use the same regimen. So if the patient got a VTD and then a transplant and they had a period of remission of 5 years, you could give again VTD or VRD or CyBorD, whatever you gave at that time. Especially if there's no toxicity, so they don't have any pre-existing neuropathy for bortezomib, they don't have any heart disease for carfilzomib, etc. You could also switch drugs. Sometimes A lot of patients, or doctors, what they do is they just switch to a different class. So if you had an IMiD base, you go to a bortezomib based. If you had a bortezomib base, you go to an IMiD base. And then if you had both, then we try alkylators, or we do clinical trials, or we try newer classes of proteasome inhibitors and IMiDs, such as carfilzomib and pomalidomide, and so on. Okay, any questions?
Thank you very much. This topic is open for question and comment. Concerning the regimen that for the relapse multiple myeloma, in case of the patient who got the lenalidomide maintenance, do you think that the regimen will include lenalidomide or not? Is it?
You can, because so lenalidomide maintenance, the highest dose that I have given is 15 milligrams daily. And that's the highest dose that they've given on clinical trials that I know of on long-term maintenance. Mm-hmm. So I usually don't increase just the dose of lenalidomide and add dexamethasone, but it also depends on patient preference. So if you talk to the patient and the patient says, I cannot get any infusions, or I don't want to add any more tablets, then one option would be you could give them a bigger dose of lenalidomide with dexamethasone. However, if the patient is willing and able to add medications, then you can add carfilzomib and give carfilzomib, Revlimid, and dexamethasone. You can give carfilzomib, pomalidomide, dexamethasone. You can give antibodies with the lenalidomide and the dexamethasone. That's in our clinic. You could add bortezomib, so if the patient has had bortezomib before and has tolerated it well, you could just add that. You could switch to a completely different regimen, but you can most certainly still use lenalidomide after maintenance. And even if you just increase the dose and give dexamethasone, that works. I don't think that's the best approach. I think that the best approach is to give a triple-line therapy if the patient can take it and is willing to take it. But
any question? If no question, thank you very much.
Thanks.
So it's a great honor to introduce our next speaker, our co-chair, Dr. James Chim. He is Professor of Medicine at Queen Mary Hospital and University of Hong Kong. He will give a talk on choice of therapy for relapsed multiple myeloma. Please welcome Dr. Chim.
Thank you very much, Chairman, for your kind introduction, and thank you very much for the organizer to invite me for the talk. So I'm James Chim from Queen Mary Hospital, University of Hong Kong. So I'm going to talk about the treatment of strategy of multiple relapse refractory myeloma. So actually, from the previous speaker, I think she's done a very great job. So despite the fact that I'm sure that many of us, or you, are very focused on what drugs to use, okay, or what trials has been done to guide the regarding what drugs to use in case of relapse refractory myeloma. But for me, I think one of the requisite or the more important question is actually the philosophy of when to treat. I think this is actually a very important question that's been addressed by the last speaker. So this is an excellent platform. So anyway, I think there are a number of factors impacting the choice and decision of salvage treatment. So obviously, first of all, is the disease. But it's either in the relapse or aggressive relapse or a patient relapsing with extramedullary myeloma. So the question is actually to treat or not to treat. So I believe that the first slide to show you is actually, for example, when a patient actually develop a CRAP, okay, the hypercalcemia, renal or end organ damage attributable to the myeloma proliferation, that always treat. But as the last speaker alluded to, there are actually some patients who actually present with a biochemical relapse. And then actually there is a recent paper by Peter Sonnenfeld in Hematologica as actually alluded to by the last speaker, that actually there is a threshold that you may consider to treat, okay? But also there are occasions when the patient has a very rapid relapse, although it's biochemical initially, but actually the doubling time, the M protein doubling time is actually very short. So in that case, actually you may consider to treat when they reach a threshold, not necessarily when they reach a CRAP. So I think it's a lot of philosophy in between. And so it certainly differs in different oncologies and also it differs in different institutions according to your policy. And also the duration of the last treatment, duration of the response of the last treatment, whether you consider reinduction or actually you consider, say, for example, a second transplant as an option. And of course, the patient's performance status, organ failure, comorbid illnesses. And also, for example, the prior treatment is the patient has got a number of novel agents and the patient has already developed resistance to all these novel agents. And also whether there is a residual toxicity from the last treatment, especially, for example, peripheral neuropathy from bortezomib and also bone marrow failure. And I think, last of all, I think all of us actually are very focused on whether there are evidence, and so whether there is scientific rationale and whether it's decision is driven by a clinical trial. So the field question remains is actually when to treat, how to treat, and actually what to treat. And so if you look at the NCCN guidelines, so actually apparently there's a whole panel of different regimens or drugs that you can use when you consider treatment for relapsed refractory myeloma. So apparently we've got plenty of options. So for example, next-gen proteasome inhibitor, the next generation IMiD, combination of the above, monoclonal antibody like daratumumab and daratumumab combinations, and then the new class of drugs like a BCL2 inhibitor, and also tumor suppressor protein exportin 1 inhibitor, and also immunotherapy. So there are a whole range of different treatments that we can choose for patients who relapse from the first response. So we focus on evidence-based clinical trials. So of course we are very focused. We prefer randomized controlled trials. So in that connection, usually the trials are designed in a way that is of comparisons between 3 drugs versus 2 drugs, and then sometimes it's proteasome inhibitor based, like the ASPIRE study comparing KRD, carfilzomib RD versus RD, and the Turmalin study comparing isosumab RD versus RD, and also IMiD-based like the MM003 study, which compares Pomdex versus Cytostax, and also monoclonal antibody-based like daratumumab. In the case of Castor, is actually comparing daratumumab VD versus VD, and Pollux is actually daratumumab RD versus RD. And also there are, the SAR antibody, which also targets CD38, and also the Eloquent-2 study, which compares elotuzumab RD versus RD. On the other hand, there are also head-to-head comparisons. I would say that actually these days we don't have many studies which are head-to-head comparisons, but we do have one study like Endeavor, which compares carfilzomib Dex versus Velcade Dex. And then we also have derivatives of the randomized controlled trials. For example, in the Pollux, we have a daratumumab RD, and then now we have some phase 2 studies using daratumumab Pomdex. And also from the MM003, we've got Pomdex study, but then we got the derivative from the study, and the way that we have Velcade Pomdex, and also we add on Cytoxan Pomdex. And in addition to all that, we also have a very important pivotal phase 2 trials for entirely refractory myeloma. So for example, we have carfilzomib Pomdex for lenalidomide refractory myeloma patients. We also have this series Gen 501 study, single agent daratumumab for refractory myeloma, and also we have the STORM study for entirely refractory disease. So at this point, I would like to ask you a question. So we know that from the ASPIRE study with the PFS in the intervention arms is 26 months, and in the MM003, Pomdex versus Cytostax, the PFS is only 4 months. So my question to you is actually, do you think KRD is a better option than Pomdex? So first of all, I think the answer is that we cannot just compare 2 studies, okay, as they are entirely different. Okay, so one thing I would like to draw your attention to is that, for example, in the KRD, the patient population is mainly early in the course of the disease, they're early relapse in a way that the median number of prior lines is only 2. So literally none of them are refractory to the last treatment, and none of them are double refractory to lenalidomide or bortezomib. On the other hand, in the Pomdex study, so basically they are refractory myeloma patients. For example, 95% of them had more than 3 lines already. So the majority of them are refractory to the last treatment, and they're double refractory to BOL and LEN in the majority. So this is just a table of this RCT of the relapsed refractory myeloma that was published in the last 2 years or so. So as you can see that the majority of these studies are published in the New England Journal of Medicine, some of them in Lancet, and some of them in Lancet Oncology. But then my point is that these RCT are intrinsically different. Well, for example, I'd like to draw attention to some of the studies that actually focus on patients who relapsed, mainly refractory myeloma patients, for example. These 3 studies basically are focused on patients who had 4 to 5 prior lines of therapy, and actually some of the studies are just focused on patients with 1 to 2 prior lines of therapy. And for example, in these 3 studies, they actually have patients, majority of the patients are refractory to the last treatment, but in the other studies, actually, very few patients are refractory to the last treatment. So basically, they're intrinsically different. So we cannot just compare the PFS by numbers. So obviously, in the last 2 years, based on all these randomized control trials, there are a number of approval, based on of different drugs based on different RCT, like Aspire, Tourmaline, Series, Trastero-Polex, Eloquent-2. And so I would like to go into daratumumab, that is the monoclonal antibody that's found useful in multiple myeloma. So I think to start with, actually, I would like to focus on the mechanism of action about this monoclonal antibody. So this is IgG1, human monoclonal antibody against CD38, which is highly expressed on myeloma plasma cells. So obviously, single agent, this drug has got single agent activity in a way that, first of all, the mechanism that is involved is that once the antibody binds to CD38, which is expressed on myeloma plasma cells, it will cause apoptosis of the myeloma plasma cells. Moreover, like any other antibody, so it will also mediate other mechanisms of cellular apoptosis in a way that, for example, CDC complement dependent cytotoxicity. You still remember the classical pathway and the alternate pathway. So activation of complement 1, 4, 2, and then 3, and then 5, 6, 4. 5, 6, 7, 8, 9, and then they will perforate the cell. And then we also have the ADCC, which is actually mediated by the NK cells have got a receptor for the FC receptor for the antibody, and hence the CD38 bind myeloma cells will be detected by NK cell, and they will execute this antibody-dependent cellular cytotoxicity. And also they have an additional mechanism, which is called antibody-dependent cellular phagocytosis, which is mediated macrophages. And also in this era of immunotherapy, I think immunomodulation, which is an additional benefit of daratumumab, is also very important. For example, so by affecting the CD38 enzymatic inhibition, so we will lead to decreased adenosine production by the myeloma plasma cells. So we know that adenosine is actually a very immunosuppressive molecule that suppresses myeloma-specific CD8 T cells at the bone marrow microenvironment. Moreover, in addition to the myeloma plasma cells, CD38 is also expressed on the regulatory T cells and also on myeloid-derived suppressor cells, which are actually cells that suppress the activity of myeloma-specific cytotoxic T lymphocytes in the bone marrow microenvironment. And so, by the administration of CD38, it will actually depress the myeloma-specific CD8 T cells and lead to activation of the tumor-specific CD8 T cells, and this will cause cytotoxicity of the myeloma plasma cells. And of course, based on that, there are very important pivotal single phase 1-2 study that shows that daratumumab has got single agent activity. So based on the Gen 501 and also series study, and a number of the patients have been given at the dose of 16 milligram per kilogram. So altogether, 148 patients. So the point is that in this study, majority of patients are highly refractory to the last treatment. They are both proteasome inhibitor and also IMiD refractory, and you can see that some of them are also refractory to carfilzomib, and some of them are also refractory to pomalidomide as well. So in this very refractory cohort of patients, they see a very good response of the refractory myeloma patients to this single agent daratumumab. And so you can see that the overall response is 30%, and a number of them develop quite deep response in the way of VGPR. So you see that actually the median progression-free survival here is only 4 months, but then it translates into a very reasonable overall survival of 20 months. So based on that, they've got phase 3 randomized control studies using daratumumab combining with RD in the POLEX and also VD in Castor. So this is a POLEX study. in which actually relapsed refractory myeloma patients have been randomized to receive either daratumumab with RD versus RD only. So in the schedule outlined here. So basically, they can be exposed to they may have a prior exposure to lenalidomide, but they cannot be refractory, obviously, because of the control arm. So the primary endpoint is PFS, and the secondary endpoint is overall survival, response rate, etc. But they also include an MRD study. So you can see that in this POLAR study, first of all, the response rate is really remarkable. More than 90% of the patients responded. And actually, many of them actually achieved a very deep response. For example, more than CR is 43% had more than CR, and almost 80% had VGPR. And progression-free survival at 1 year is 80%, so it's really, really remarkable. But then if you look at the cluster trial, again, it's similar patients, relapsed refractory myeloma patients randomized to receive daratumumab plus Velcade-dex versus Velcade-dex. But in this study, only X cycles of VD are given in both arms. And then in the intervention arm, so they will, after the X cycles of VD, they will receive a single agent daratumumab every 4 weekly thereafter. So again, similar endpoints. So what you see is, again, a very high response rate. You see a response rate of more than 80%, and actually the VGPR rate is actually almost 60%. So very impressive result, and a very impressive PFS too. So now we move on to another monoclonal antibody, the elotuzumab. Okay, so this is actually an antibody against SLAMF7, or in the past it's called CS1. So this molecule is actually mainly expressed on myeloma plasma cells, but also on normal NK cells. Okay, so the mechanism of action is that when this elotuzumab binds to NK cells, okay, by binding to the SLAMF7 expressed on NK cells, they will lead to activation of NK cells, okay, in the first place. But they don't have single agent activity against the myeloma cells. So what do they do? So what they do is actually when they actually circulate and find a myeloma plasma cell, they will bind to the SLAMF7 on the myeloma plasma cells. And then what happens is that the activated NK cell will exert the antibody-dependent cellular cytotoxicity against the elotuzumab-bound myeloma plasma cells. Okay, so in this, so therefore there is a randomized control study using elotuzumab plus RD versus RD. So you see that in this study, again, the response rate is almost 80%. Some of them achieve a very good, relatively deep response, and the progression-free survival is 19 months versus 14 months. So there is a survival advantage. And then after all these trials, we also have some clinical trials that are conducted in patients with very advanced disease. For example, in this in the series and the Gen 501 that I have already alluded to, so they are very refractory patients. And now I would like to talk about this MM003, this Pomdex versus high-dose dex. So in this study, again, this literally, as I alluded to earlier on, so this is comprises patients with very refractory disease. And then you can see that patients will randomized to receive Pomdex versus high-dose dex, and the response rate is around 30%, and occasional patients will achieve a relatively deep response. And you see that the PFS in the intervention arm is only 4 months, okay, which is actually similar to the series and Gen 501 study. So beyond all these popular RCTs, for example, the Aspire, Castor, Polax, or Eloquent 2, so we can have other combinations using next generation proteasome inhibitor or IMiD, or anti-PD-1 antibody, or even the transplantation strategy. So for example, we have a next-gen PI in non-refractory patients combining Velcade pomalidomide dex, or actually we also have a carfilzomib combining with pomalidomide dex study. Well, moreover, in addition to the POLAR study, we have a daratumumab added on to RD. Now we have a clinical study using daratumumab with Pomdex, and also we have anti-PD-1 antibody together with Lendex, or actually anti-PD-1 antibody with Pomdex, and then we have a transplant strategy. And then we also have other agents that target BCL2 with Nacloclax as a single agent or in combination. Also, we have agents that target exportin 1, selenizumab, and also we have CAR T cells. So there are a whole wide range of different treatment. So again, just look at this next-gen combination in the LAM refractory patients. So as alluded to, we have Velcade Pomdex. For LAM refractory patients, in the past we have Pomdex only. Now we have Velcade Pomdex. So this is actually a study by the Mayo Clinic by Dr. Lassi. So basically, this is addition of the Velcade to Pomdex backbone. So you see that in this entirely lenalidomide refractory cohort of patients, they have very high response rate. More than 80% of the patients responded, and many of them actually develop a relatively deep response in the way of more than VGPR, and actually median progression-free is 10 months. So, and besides Velcade Pomdex, we also have carfilzomib added on to Pomdex, which is actually on clinical trial now. So in the daratumumab side, besides daratumumab, we together with RD in the POLIS study, now we have daratumumab with pomalidomide dex, which is a study which is ongoing. And also we have agents that target BCL2. For example, we have venetoclax. So what's a venetoclax? Venetoclax is actually a BCL2 inhibitor. So we understand that so the cells, when they undergo oncogenic transformation, they will induce apoptosis by upregulation of tumor suppressor genes like P53. In that case, what they do is actually they have to induce apoptosis via the mitochondrial pathway. So in that sense, usually the BACs or the back protein have the homo-oligodimerize, and they punch holes in the mitochondria and leading to formation of the apoptosis and then intrinsic apoptosis. But however, in the tumor cells, because BCL2 is upregulated, so BCL2 will sequestrate these BACs and the back proteins, and hence the cells cannot go into apoptosis. So therefore, there are studies using venetoclax, which is BH3 domain molecule that inhibit BCL2, and because of the risk of tumor lysis, as illustrated in the case of chronic lymphocytic leukemia, so there's a ramp-up program, and then you can see that in this single agent study with a single agent venetoclax in relapsed refractory myeloma. So majority of the patients are actually quite refractory to last treatment, or they are double refractory. So in this study, although it is not, you can see that actually the major response occur in patients harboring 11-14 translocation, that is, they have upregulation of cyclin D1. Okay, so moreover, if you look at the time to progression survival curves, so actually the best survival curves belongs to those with, again, with 11-14 translocation. So the question is, why does the drug fail in those without 11-14 translocation? So it is mainly due to the concomitant upregulation of MCL1, which is like BCL2, is another protein that inhibits apoptosis. And therefore, because of that, there are actually current ongoing study using venetoclax, which is combined with bortezomib and dexamethasone. And the reason for that is that we understand venetoclax single agent will inhibit BCL2, and then because the concomitant upregulation MCL1, so they use the actually bortezomib, actually which will inhibit will downregulate MCL1. So therefore, there's a current ongoing study combining venetoclax with bortezomib and dexamethasone. And also we have another drug that has got a very interesting mechanism, selinazole. So this drug is actually an exportin 1 inhibitor. So what's exportin 1 is illustrated in this cartoon. So you see that exportin 1 is depicted by this red molecule. So exportin 1 actually transports tumor suppressor proteins or actually glucocorticoid receptor to the cytosol. Okay, but using exportin 1 inhibitor, they will actually cause a retention of this tumor suppressor protein and also glucocorticoid receptor in the nucleus, and this will lead to apoptosis of the myeloma cells. So in this study, they actually are very brave. They conduct a study with with this selinazole with low dose dexamethasone in very highly refractory myeloma patients. So you can appreciate how refractory they are. So for example, these patients are at least quad refractory in the way that they're refractory to bortezomib, to carfilzomib, to lenalidomide, and also pomalidomide. And also, they've got some patients who are penta-refractory in a way that in addition to these 4 drugs, refractoriness to these 4 drugs, they are also refractory to daratumumab, okay? So let's see the response. So of course, the PFS in this case is actually less than that in the series trial or in the MM003, which were 4 months. So here is only 2.3 months. But you do see a number of patients with this penta or quad refractory patients developing a response, a decent response. And the time to response is only 1 month. And the interesting point about this is that if you see the overall response in this highly refractory patients is 20%, okay? But if you look at you break the response down into category according to the cytogenetic risk category, you can see that actually more response occur in patients with a high risk cytogenetic than patients with standard risk cytogenetic. Although this is not a very big study, but I think this point is actually quite interesting. So, of course, apart from that, we do have an immune checkpoint inhibitor. So we do have 2 checkpoints. One is in the central checkpoint in the lymph node that was responsible for the priming and activation of myeloma-specific T cells. Then also we have another checkpoint at the peripheral side and the tumor side, that is the bone marrow, where we can actually target by anti-PD-1 or anti-PD-L1 antibody. And therefore, currently we've got anti-PD-1 antibody in combination with Lendex and also anti-PD-1 in combination with Pomdex. So, besides all those published RCTs, we from Aspire, Castor, Pollux, or Eloquent 2, we do have a whole array of different strategies. And so to summarize it in a cartoon, so first of all, we can use the next generation IMiD like RD or Pomdex, and then we can use the combine this next gen IMiD with Velcade, or actually we can combine this next generation IMiD with carfilzomib, and then we can use a monoclonal antibody like a CD38 antibody daratumumab, okay, in different combinations. Then also Eloquent, the elotuzumab with RD, and then we can also use a BCL2 inhibitor like venetoclax in the different combinations. And I understand that there is a recent development in MCL1 inhibitor too. And then we can also use exportin-1 inhibitor, say sildenafil, together with low-dose DAX. And then we can also use anti-PD-1 antibody to actually reactivate this myeloma-specific T cells in the bone marrow microenvironment. And of course, we can use CAR T cells to target BCMA in case of myeloma. So thank you very much for your kind attention.
Okay, thank you very much. This topic is open for question and comment. We only have one question. Can I ask you one question concerning the relapsed patient? In those who are relapsed to regular regimens, do you think in which case will you add that monoclonal antibody to the regimen, for example, IMiDs or proteasome inhibitor?
Bortezomib.
I mean, which group of relapsed patient will you add the monoclonal antibody, for example, anti-CD38?
So actually, what do you mean? Actually, you want to use single agent daratumumab or
combine
in combination? So it
yeah,
depends on what you have used.
You will add monoclonal antibody to the regimen, for example, lenalidomide or bortezomib, dexamethasone, something like that.
All right. So I think actually what do you use actually depends on what you have used. Okay, so for example, if you use, in our case, in transfer-eligible myeloma patients, we use a VTD for induction, and then of course we can use, if I consider for a second line, I can consider RD, and if we can afford to use daratumumab, I can use a daratumumab plus RD like the Pollux trial. So it depends on what you have used in the first line, and how long does the patient relapse from first line. Okay, so I think there are a number of different considerations. So you look at the PFS, Pollux study is really remarkable. So, but of course, I don't have time to go into the difference between the Castor and the Pollux. Actually, the dose intensity of Pollux is actually higher than that in Castor, especially when the patient receiving maintenance daratumumab in the maintenance phase. Because in the Pollux study, the intervention arm, they receive every 4 weekly daratumumab plus RD. But in the case of Castor, when they reach maintenance therapy, they just receive single agent daratumumab every 4 weekly. So that's why I believe that translates into a difference in the response rate, and also it translates into a difference in the survival.
Okay, thank you very much.
Thank you. So it is my great pleasure to introduce the next speaker, Dr. Robert Orlowski. So I think he needs no introduction at all. So Bob is actually an expert in myeloma, and he's actually the chair in the Department of Lymphoma and Myeloma in MD Anderson Cancer Center. So Bob is going to talk to us about the changing landscape of myeloma therapy, and he's got a focus on proteasome inhibitor. So Dr. Orlowski, please.
Well, thank you very much. It's my pleasure to be here, although I have to say it's not my pleasure to follow Dr. Chim's talk, because I think he told you everything there is to know. So I'm not sure that actually I can tell you anything new. But nonetheless, I'm going to do my best, because that's what they asked me to do. And I'm going to mostly talk about proteasome inhibitors and maybe go into a little bit more detail because I have a smaller topic than did he to talk about. Just to give you some introduction into the biology, of course, you know that ribosomes are the parts of cells that make new proteins, and you also therefore have to have a mechanism by which to get rid of proteins, either because they're damaged or because they haven't folded correctly, or because some proteins you just don't want to have around for a long time. For example, the cyclins need to be there during cell division, but then you want them to not be there. And so the major way that that happens is through the ubiquitin proteasome pathway. The proteasome itself is shown here. The core is what's called a 20S particle, which has 4 rings, one on top of another. Each ring has 7 subunits, and in the middle is a channel, which is ultimately where the proteins that are going to be digested get fed. So this is a really animation that shows you how ubiquitin-dependent proteolysis occurs. And on the right, you have what's called the 26S proteasome, which has that 20S core and some regulatory proteins at the top and at the bottom. So if you have a target protein that you want to digest, the first thing that you do is you take ubiquitin with an E1 activating enzyme and ATP, and you form a high-energy bond. The ubiquitin is then transferred over to an E2 ubiquitin conjugating enzyme. An E3 ligase then comes in and forms a further complex to which the target protein binds. The ubiquitin is then transferred to the target multiple times, giving you a chain of ubiquitin molecules. That chain is recognized by the proteasome, and the ubiquitin is cut off and recycled. And in the meantime, the protein is fed into that central chamber that you saw earlier and digested into short peptides. Probably the reason that the proteasome is a good target for myeloma is in part illustrated in this figure, which Dr. Manasank and I put together for a paper that should be coming out later this month in Nature Reviews Clinical Oncology. And it turns out that myeloma cells are very finely balanced between their ability to digest protein and the amount of protein that they have to digest. That's a lot because they make a lot of immunoglobulins. Either the malignant plasma cells do that, and a large protein load puts stress on the cell. If you block the proteasome, you disturb this balance because the load of the proteasome goes up because there are more proteins that have to be digested, whereas the capacity goes down because you're inhibiting the proteasome, and as a result, that balance is disturbed, and that can trigger apoptosis. So you may remember way back when, I'm not sure actually that I do, but bortezomib was found to be active against myeloma in a phase 1 study, which really led to further trials, including Paul Richardson's phase 2, which had a 10% complete response rate as a single agent. And back then, it was very unusual to have complete remissions in the relapsed and refractory setting. And of course, that was confirmed in a randomized trial compared to dexamethasone. Later on, various combinations were tried, and there are many of these now that are FDA approved. But the first one was bortezomib with liposomal doxorubicin. This was without dexamethasone. And you can see a 9-month progression-free survival. Probably if you added Dex, this would be maybe 13 or 14 months. So this is still a reasonable combination. But when Dr. Manasank and I actually put together this review, we went through and looked at all of the major trials, and there are actually 3 pages worth of these trials in the review. So I won't go through them in detail, but again, hopefully this will be available online at the end of January for you to look at. Because bortezomib resistance was something that occurred fairly rapidly when you used it as a single agent, there was an effort to try to identify new drugs that could maybe overcome that. And in these preclinical data from Deborah Kuhn in my lab, we were able to show that carfilzomib was able to overcome bortezomib resistance. And there were a number of phase 1 studies done with different dosing regimens, which did show ability clinically to overcome resistance. And that, of course, led to the single-agent carfilzomib trials, which showed about a 25% response rate in relapsed and refractory myeloma. Combinations are always going to be the way to go, and so a number of people, including Michael Wong at our center, looked at combinations like carfilzomib with lenalidomide and dexamethasone, and you can see a nice overall response rate of 70 to even 80%. And that set the stage for the ASPIRE trial, which compared Lendex with carfilzomib Lendex. And Dr. Chim did review these data a little bit, but just to provide you with a little bit more detail, the KRD arm had a much better overall response rate as well as stringent complete response rate. And you can see that the CR rate is tripled. Not too often that you see such a huge improvement in responses with the addition of just a single drug. The progression-free survival data are shown here, and you can see a big difference, about a 10-month difference in the progression-free survival. And even though the curves later do come together, the reason that happened is that where you see the dotted line, carfilzomib was stopped in the KRD arm because there was a really desire to make it more convenient for patients so that they wouldn't have to continue coming for IV therapy. And the chances are that if carfilzomib had been continued, the curves would have continued to be separate. The subgroup analysis really shows that KRD was better than RD in just about every patient population. And also there was a relatively low increase in adverse events given the dramatic benefit clinically. You can see serious adverse events, for example, only went from 54% to 60%, which I think is relatively modest. Other changes that may be coming with carfilzomib, there are data, of course, that high-dose carfilzomib could be effective. The previous dosing regimens were 20 milligram per meter squared on days 1 and 2, followed by 27 milligram per meter squared in later doses. But in this study from Nicoletta Lenvide, they were able to show that even higher doses, up to 56 milligrams, could be given on 2 days consecutively. And so that, of course, supported the Endeavor trial that you heard from Dr. Chim about, which was KD versus VD. The toxicities of interest are shown here. There was less neuropathy with carfilzomib, which I think we all know about at this point. There was some increase in cardiac effects, but this was relatively low. The benefits, though, were that the complete response rate or better was double with the high-dose carfilzomib compared with bortezomib and dex, and the VGPR rate or better was doubled as well. PFS is shown here, and you can see a very nice separation, which is very statistically significant. And the updated efficacy that were presented recently in a paper that's now available online, with the first author being Weiju Chung, you can see that in high-risk patients as well as in standard-risk patients, the carfilzomib-containing regimen was better. And the same was true for older patients, meaning 75 or older, middle of the road, which is 65 to 74, and younger patients who were less than 65. The benefit was seen throughout. One new approach could be to give oral proteasome inhibitors right now. The first one available in the clinic in some areas is ixazomib, and this was compared in the combination of Len-Dex compared to just Len-Dex alone. And you can see the progression-free survival data are quite nice, with a separation showing that the 3 drugs are better than the 2 drugs. And again, in the subgroup analysis, just about all of the patient subpopulations did better with the oral proteasome inhibitor and Len-Dex. If you like to look at the response rate data themselves, you can see that the responses were a little bit better with the ixazomib Len-Dex, especially if you look at VGPR rate or better. And also you had a much more rapid time to response, 1.1 months versus 1.9 months. The other thing is, as was the case with carfilzomib, ixazomib had a very good safety profile. With the first dose, there can be some GI effects, but after that, the added toxicity is relatively mild to perhaps even none at all. And so from the perspective of what gives you a nice benefit with very little to no added toxicity, I think that ixazomib is certainly a very attractive drug. There are other oral proteasome inhibitors that are coming as well, and aprozomib is one of those. This is chemically in the same class as carfilzomib. Ixazomib has a boronic acid like bortezomib. Aprozomib has an epoxy ketone like carfilzomib, and there are nice data that have been already out there with aprozomib Pomdex and in other combinations. There's a new formulation of aprozomib that was developed because the previous one had a little bit more GI toxicity, and with this new version that has less GI toxicity, new studies will be performed, and hopefully maybe you'll be able to be part of some of those. You can see from the waterfall plot that this is really a dramatically effective combination, and certainly an all-oral regimen is very attractive for patients who want to spend as little time in the hospital or the clinic as possible, and also hopefully not travel back and forth. So there are still many studies that are ongoing with bortezomib, carfilzomib, ixazomib, and aprozomib, and I don't think we've yet maximized the benefit of this class of drugs. Here's just a few. One of them I mentioned earlier in the upfront talk, which is the one comparing VRD to KRD in the newly diagnosed setting. That one is about half accrued. It's an ECOG study, and hopefully we'll see results of that fairly soon. And also there is a study looking at giving carfilzomib once weekly as opposed to twice weekly. The once weekly dose is at a higher level, but hopefully that will maximize convenience while reducing cost as well, because you're only giving the one dose, and hopefully preserving efficacy, and that will be great for patients as well. Other studies that are ongoing in myeloma include a maintenance study of ixazomib after transplant versus placebo, and also a study in newly diagnosed myeloma patients who are not transplant eligible, which looked at ixazomib Lendex versus Lendex. And all of these, we think, should be coming to maturity in the next year or two, and I think that'll be an exciting time for proteasome inhibitors. Now, this is a myeloma session, but I thought I would include a little bit of some of the studies that are ongoing in related diseases. Bortezomib and ixazomib are being looked at in amyloidosis, and Dr. Parmar will later give a presentation on some of the therapeutic options in that disease, but clearly proteasome inhibitors are very important, and there also are studies looking at whether proteasome inhibitors like carfilzomib could be effective in Waldenstrom as well. Also, ixazomib and carfilzomib are being looked at AL amyloidosis and Waldenstrom in other studies. So the conclusions I think that I would leave you with are that proteasome inhibitors have already made a dramatic impact on myeloma, both in the newly diagnosed, relapsed, and refractory settings, as well as in other diseases like Waldenstrom and amyloidosis. Their generally good tolerability and efficacy, as well as their ability to combine with almost all of the other drug classes that we use, make them a backbone agent. We've got lots of new drugs that are coming, and some people would argue, well, maybe we won't be using proteasome inhibitors anymore. But for me, I think that because this unfolded protein response, or the stress that the large load of protein causes to myeloma cells, that this is really a key weakness for myeloma, and therefore we're not going to be getting away from using proteasome inhibitors anytime soon. Convenience is certainly being improved by oral agents, and the oral agents will also be very hopefully good in maintenance. We certainly need more comparative and randomized studies because we don't yet know whether carfilzomib is better than bortezomib. We showed you some of the data, but there was also, as I mentioned earlier, the carfilzomib melphalan prednisone versus bortezomib melphalan prednisone trial, which did not show a difference. And we certainly need to look at cost effectiveness as well as patient-reported outcomes, because these will be important in deciding which regimens to use in the future. And then finally, where are we going in the future? Fortunately, we're developing a better understanding of what may predict sensitivity and resistance to proteasome inhibitors, and hopefully what will predict for toxicity. Mechanisms of resistance are important because if we could prevent those or overcome them, we could extend the benefit of these drugs. And one thing we don't have a lot of yet are studies with immuno-oncology agents. You saw the data with bortezomib and daratumumab, but can we give bortezomib in combination with PD-1 blockers, for example, PD-L1 blockers? Can we give them with CAR T cells? These are still open questions that we need to answer both preclinically as well as clinically. So thanks very much. I think I've covered my topic, and I'm happy to take any questions that you may have.
Okay, thank you very much. This topic is open for question and comment. Yes.
Yeah, thank you so much for the excellent talk. I have a question regarding amyloidosis. For patients who have some partial response after bortezomib-based regimens in terms of hematologic response only, but no any evidence of organ response at all. Do you have any comment or recommendation for that?
Well, it's a great question. I don't want to steal Dr. Parmar's thunder too much, but I guess since she walked out, I can say whatever the heck I want at this point. I think part of the problem, is that the organ responses take much longer to appear than do the hematologic responses in amyloid. So if you've had a very good heme response, but no organ response yet, one option is to continue therapy and hope that with a longer period of time you can get some improvement. The other option that will be coming soon is there are a couple of antibodies now that are directed specifically against the amyloid fibrils. One is the Prothena antibody called NeoD001, and the other is one that is called 11-1F4. These are monoclonals that, as I mentioned, don't bind to the monomer light chain, but they do bind to the fibers, and they help to clear the light chain's fibers. So I think in the future, what we'll be doing is probably using these antibodies with proteasome inhibitors right away, or maybe you'll do a proteasome inhibitor first. If you don't get an organ response, then you'll add that antibody. But again, Dr. Parmar will clarify all of this for you in her talk on amyloidosis.
Thank you so much.
Any question?
All right, thank you very much.
Thank you very much.
So we're going to move on to the next talk. So shall we invite Dr. Elizabeth Steve Monasant? Elizabeth is actually assistant professor in the Department of Lymphoma Myeloma of MD Anderson Cancer Center, and she's going to talk about immunotherapy novel agents for relapsed myeloma.
So if Dr. Orlowski was worried after Dr. Chim's talk, imagine how worried I am now after Dr. Chim's and Dr. Orlowski's talk. So I'll do my best. A lot of the things I'm going to mention have already been mentioned, just because these are so important that when you talk about relapsed myeloma, you just have to mention them. So probably after this talk today, you're going to remember all these very important things, which is also good. So I'm going to talk a little bit about novel agents and also immunotherapy. We've already discussed that there are some factors for treatment selection for relapsed myeloma, including disease-related, regimen-related, and patient-related. In the case of immunotherapy, what we want is to use our own immune system to fight multiple myeloma. In the area of novel agents and immunotherapy, if you look at this slide, this is a very, very positive and happy slide, because there are so many medications here, and most of these medications are actually either approved for the treatment of frontline myeloma or relapsed myeloma, or they're going to be approved soon because they have so much efficacy in early trials that it's likely that they will be approved, for example, some of the checkpoint inhibitors. So this is actually, it's a great time to be in the myeloma field. And so I just love this slide. It's fantastic. So Dr. Orlowski has mentioned ixazomib, carfilzomib, oprozomib, and bortezomib, which are the cornerstone of treatment for myeloma. He's mentioned the advantages and disadvantages of all of them, and I just wanted to mention about carfilzomib that it binds irreversibly to the beta-5 catalytic subunit. It's intravenous, and it has some side effects, including cardiac and much less peripheral neuropathy. You have here some of the mechanisms of action, which actually Dr. Orlowski has already gone over. As Dr. Orlowski mentioned, he did position 1 phase 1 study with carfilzomib, Revlimid, and dexamethasone. These are 2 phase 1/2 studies with this combination in newly diagnosed myeloma that achieved very good rates of complete remission, more than 50%, including without the use of autologous stem cell transplant. There is currently an ongoing phase 3 study, which is a very important study. That's why it's been mentioned several times today, which is comparing carfilzomib or bortezomib with lenalidomide and dexamethasone. This is the study schema. It has been shown here. It also has 2 randomizations, the first one to bortezomib or carfilzomib, and the second one to lenalidomide for 24 cycles or lenalidomide until progression and toxicity. So this is going to be a really important study. It is also important to mention that stem cell collection in this study is encouraged, but upfront autologous stem cell transplant is not mandatory. Ixazomib is, I guess, the golden child of proteasome inhibition right now because it's the first oral proteasome inhibitors, and patients love it. The alternative is coming to clinic once or twice a week to get bortezomib, or coming twice a week to get carfilzomib, which is an infusion, and they have to be in the infusion center for a little bit. So obviously this has created a lot of interest. MLN9708, or ixazomib, is administered orally, and then it is transformed through hydrolysis to a biologically active form, which is MLN2238, which then binds to the chymotrypsin, trypsin, and caspase-like domains in the proteasome and inhibits proteolysis. This study has also been mentioned a couple of times. Dr. Chim mentioned it, Dr. Orlowski mentioned it. It's a very important study which led to the approval of ixazomib for the treatment of patients with multiple myeloma. In this study, the addition of ixazomib to Revlimid and dexamethasone showed an increase in progression-free survival. Additionally, this was true, or the effect was true for proteasome inhibitor-exposed patients, for example, to bortezomib, and also it was effective in patients that had, for example, high-risk cytogenetics. Oprosomib is also the other golden child. It's not yet approved, but I'm very happy to hear that they are, I don't know where Dr. Orlowski went, but I'm very happy to hear they formulated a new one, because this is an irreversible form. So the ixazomib is a reversible form of the proteasome, similar to bortezomib, and this one is similar to carfilzomib. So given that in the clinic sometimes we do see more effect with carfilzomib, although this has not been yet compared in a phase 3 trial except in this one with melphalan and prednisone, but I wonder the dose of carfilzomib. You know, if you give the maximum dose of carfilzomib, there's also been a study comparing carfilzomib dexamethasone with bortezomib dexamethasone, in which the carfilzomib dexamethasone arm actually showed also improved clinical outcomes over bortezomib dexamethasone. So that, I believe that there is some dose response. So we would have to see what was the dose in that melphalan prednisone study. In any case, oprosomib has shown very good responses, and really the main issue was that it had some toxicities, and I hope that these ones have now been resolved. As you can see here, I mean, in the bottom of the slide, this, or Dr. Orlowski mentioned this, oprosomib with pomalidomide and dexamethasone, an all-oral regimen, probably with very effective medication, 71% overall response rate in patients that were relapsed and refractory myeloma. So this would be a very, very nice regimen if we get to it. Pomalidomide is another regimen that we use a lot in the clinic that is also relatively new, and it's a second-generation immunomodulatory agent that has a lot of effects, including cytotoxic effects and modulation of the immune system. The phase 1 study where this was explored for pomalidomide showed some responses, and then this went to a phase 3 study that showed about an overall response rate of 30%, and was more effective than the comparison, which was high-dose dexamethasone. Here, in this slide, what I am going into a little bit more is that there's a study that we did at MD Anderson. Dr. Shah was the PI, the principal investigator, with a combination of carfilzomib, pomalidomide, and dexamethasone, and this study showed that this combination is actually highly active. So in patients that were all refractory to lenalidomide and most refractory to bortezomib, the overall response rate was 50%, and 16% of patients had very good partial responses. So it's a very effective regimen. Panovinostat is a histone deacetylase inhibitor, and here you have the mode of action that is approved for treatment of myeloma. HDAC6, which is what panovinostat inhibits, mediates the agrosome and autophagy pathways, which are involved in protein degradation, so it's basically a synergizer of proteasome inhibitors. The Panorama 1 study, which has been mentioned here already, showed that there was a very significant increase in progression-free survival, especially for patients that had exposure to prior immunomodulatory agent, bortezomib, and also had more than 2 lines of therapy. So this is the current approval for the use of panovinostat in combination with bortezomib and dexamethasone. The progression-free survival for the overall population also was favoring the panovinostat arm. So there are many, when we talk about immunotherapy, there are many important targets or many potential targets. You've all heard about CD38 with daratumumab. You may have heard of isatuximab. You've heard about aslam-F7, ilotuzumab. Here we have pembrolizumab and nivolumab. You may have heard of those. Ciltuximab has been mentioned here. And then there are other targets like BCMA, etc. So this has been mentioned already, the mode of action of ilotuzumab, which is an antibody that binds CS1 in the surface of the myeloma cell and directs the immune system and activates and targets this cell. Ilotuzumab has been investigated in a phase 3 study, which led to its approval in the United States with an endpoint of primary progression-free survival and overall response rate patients with relapsed and refractory myeloma with 1 to 3 lines of prior therapy, with some of the patients with prior lenalidomide exposure, but not much, and were randomized to ilotuzumab with or without, lenalidomide and dexamethasone with or without ilotuzumab. And what we see here is that the responses were clearly favoring the arm that had ilotuzumab, including a much prolonged overall survival. Daratumumab is another antibody which is very important, has been mentioned here. I do believe that this antibody has changed how we treat myeloma, and it's probably one of the probably most important introductions in immunotherapy for myeloma, and it really has signaled, I think, a new era. So the fact that we now have antibodies for myeloma for the last year and a half or so, it has really changed the landscape of how we treat these patients. So I just cannot emphasize enough how important it is that we finally do have antibodies that are effective for the treatment of this disease. So daratumumab, again, is an IgG1 monoclonal antibody that binds CD38, and here you have all the mechanisms of action. Daratumumab was first studied in a phase 1/2 study with 100 patients who had a median of 4 prior lines of therapy. And what you can see here is that the average response lasted 8 months, so they have durable responses. And you can see here in the swimmer's plot the responses, including patients having a complete remission, which isn't usual to see. It isn't usual to see complete remissions in patients who have had a median of 4 prior lines of therapy. So this was an indication already that this was potentially a very good therapy. There was also preclinical evidence that this antibody response with daratumumab could be enhanced with the addition of immunomodulatory drugs. So there have been studies both with daratumumab in combination with lenalidomide and with pomalidomide and dexamethasone, and what you can see here are the overall response rate for this initial studies that showed that definitely this was an improvement with the original phase 1 study that showed a lower response rate. Another antibody is isatuximab. This is also a CD38 antibody that has already shown very good response rate as single agent in relapsed refractory myeloma with an overall response rate of 27% in a population that was 41% quadruple refractory and 88% double refractory. I'm mentioning here that we are trying very hard to do immunotherapy in patients with smoldering myeloma who have a higher risk of progression to myeloma. And so we have a study at MD Anderson that is opening hopefully in the next couple of weeks using isatuximab in this population as a single agent. And patients can receive treatment for a total of 2.5 years unless they have progression to multiple myeloma or toxicities. Additionally, I think that we need to talk about the checkpoint inhibitors. The mechanism of action, as you can see here, they are molecules, for example, the anti-PD-1 antibody or anti-CTLA antibody that bind to proteins in the surface of the immune cells and use these to activate, basically to release the brakes or inhibitors in the immune cell to activate and also potentiate the immune system. Pembrolizumab, which is a PD-1 antibody, targets anti-PD-1. The ligand for PD-1, which is PD-L1, is expressed in myeloma cells. This agent was tried as a single agent in relapsed and refractory myeloma, and there was no activity. However, there has been a lot of activity in early phase studies in combination with lenalidomide with an overall response rate of 76%. There have also been a study with pomalidomide, which is what I'm mentioning here because it's one of the latest ones that have been reported. After 24 months of treatment, with initial treatment of pembro, pomalidomide, and dexamethasone, patients could continue pomalidomide and dexamethasone until progression. Patients should have had at least 2 lines of therapy. The median was 3 lines, and 27 patients were treated. 82% were refractory to proteasome inhibitors, and 70% were double refractory. And this was the overall response rate for the overall population was 59%, which is also pretty good, considering that patients were most of them were refractory, at least to a group of medications. We have already started a study with pembrolizumab as a single agent in smoldering myeloma. This study is almost about to be completed, and we'll probably be presenting the results at ASCO. The interest in studying pembrolizumab in smoldering myeloma is that the expression of PD-L1 has been linked with an increased risk of progression from the precursor gammopathies to multiple myeloma. Here you can see the schema of the study that we are using. Additionally, we probably need to talk about ipilimumab, which is the CTLA-4 inhibitor and is approved for the treatment of advanced melanoma, where it was a breakthrough. There are currently several clinical trials that are ongoing, either as a single agent or in combination with nivolumab, which is a PD-1 inhibitor, for the treatment of relapsed myeloma. And I don't know yet of any data that has come out of this. At MD Anderson, we're also planning a frontline ipilimumab and nivolumab study with or without lenalidomide and dexamethasone for the treatment of myeloma. And the basis of this is to do a proof of concept that immunotherapy might be able to achieve good responses and, in the treatment of newly diagnosed myeloma. I think there's a talk after this about CAR T cells, so just very briefly mentioning that how CAR T cells are obtained. There's this first T cell collection, then the T cells of the patient are manipulated to express certain receptors that can identify myeloma cells, and then there is usually lymphodepletion, and then these cells are given back to the patient so that they can kill the myeloma. So there have been several studies with CAR T cells. I'm just mentioning one here with targeting BCMA that is done at the National Institutes of Health in Bethesda, Maryland. BCMA is a member of the tumor necrosis superfamily. It's expressed in 60 to 70% of myeloma cases. So this is already a big limitation because not everybody can get this therapy. So that's a little bit annoying. So we need to get better targets that everybody with myeloma could get. They treated, as of the last time that I saw a publication on this, 12 patients with a median of 7 lines of therapy. So these are really usually patients with very aggressive myeloma who are not responding to anything, and then they go and do CAR T cells. Here they were using these medications for lymphodepletion, and they evaluated 4 different doses. The patients that had the higher doses, and here you have the 9 million cells, also had the most toxicity with cytokine release syndrome, but one had a stringent complete remission and another one had a partial response after 4 weeks of treatment from the initial treatment. So this was the first trial to show the activity of CAR T cells in myeloma, so it's an important study. This is Dr. Kockendorfer, who is the principal investigator at NIH. Additionally, we have the BiTEs, the bispecific T cell engager, which bind the immune cell to the myeloma cell, and they avoid the need for more recruitment of accessory molecules and other cytokines. So this molecule here, BI-836901, is currently a BCMA BiTE that is in phase 1 escalation studies that is ongoing in patients with relapsed and refractory myeloma, and I also don't know data for this. So what is the summary for all these? I mean, we have so many medications. So there have been major advances in genomics that give us a lot of more understanding about multiple myeloma, and also in immunology that really do pave a bright future for the treatment of myeloma. These therapies with monoclonal antibodies, I think that we have in myeloma, We have the proteasome inhibitors, which is a big backbone. Then we have the immunomodulatory drugs, which is another backbone. And we are now having another backbone, which is going to be the monoclonal antibodies. BiTEs might be the future as well. They might work really well. And then the combination with treatment with immunotherapy at front may be the way to treat myeloma in the near future. These are the combinations that Dr. Orlowski mentioned earlier. And I just want to a little note that high-risk aggressive myeloma still is a big challenge. However, some trials have suggested that immunotherapy might also have some more responses in this population, so that might be a little bit of the bright side. Okay, and I'll take any questions.
Can I ask one question? In case of monoclonal antibody for multiple myeloma, do you see any problem in terms of determination of M protein after treatment?
Can you repeat the question?
In M protein, myeloma protein, after you evaluate the response, do you have any problem? Because the monoclonal antibody is immunoglobulin, so if you give it, you remain in the body, yeah?
Yeah, you're asking if there's any interaction when we give an antibody, if we see an increase in the
when you have a monoclonal antibodies in the circulation, and when you evaluate the M protein after treatments, this protein will add up the number of the protein that you have.
So in the clinic, we have not seen this. So I know that there was a lot of talk before we started using antibodies, and I don't know if Dr. Orlowski will have another idea, but in the clinic using daratumumab and using elotuzumab, I have not seen a fake increase in or false positives or false negatives in the electrophoresis when I give antibodies. So I don't think it's a big issue. I don't know if Dr. Orlowski has seen anything different or no, you have to talk.
Actually, at the lunch symposium, I have a few slides on that, so tune in then. That's a little shameless promotion.
Is the timing of giving the monoclonal antibodies important? Do you have anything that upregulates the CD38, for example, and then you give it? Any of the other treatment might improve the responsiveness?
That's a very good question. So first of all, it's so early on that we're using monoclonal antibodies. When we started using monoclonal antibodies about a year ago, all the patients that got the monoclonal antibodies were the patients that had already had 10 lines of therapy. There was nothing else. And then we started them on the antibody because that was the new medication, right? And now as we are treating more and more patients and we're seeing more and more patients earlier on, and there is the option to actually give them elotuzumab or daratumumab because they are approved after one line of therapy, we are using those medications more. So it's very early on because for first relapse, I'm not sure, if there's going to be any problem because to me, it's too early on to say. Because when you have a patient that has first relapse and then you give them daratumumab with Revlimid and dexamethasone or daratumumab with pomalidomide and dexamethasone, the PFS for that patient is very long, unless they have very bad myeloma, in which case not much that you give them is going to work very well for a very long time. So the truth is that I'm not sure if it's going to make a difference, such as if you give first line VRD and transplant and Revlimid, and then when they progress, you do daratumumab, Revlimid, Dex, and then when they progress, are they going to still be sensitive to other medications or the same way? I'm not sure. I think it's too early on to know. It definitely downregulates, I think, CD38. So I have seen cases of patients that turn CD38 negative with the treatment of daratumumab. But it's too early for me to tell. I mean, most patients that are on first line or second line, they're still on the drug, and you know, I don't know what I'll give them next, but
Thank you very much.
thanks.
It's my great pleasure to introduce next speaker, Dr. Richard Chaplin. He is a chair and professor of medicine, Department of Stem Cell Transplantation and Cellular Therapy, Division of Cancer Medicine, University of Texas, MD Anderson Cancer Center. He will talk about changing landscape of myeloma therapy, focus on cell therapy. Dr. Chaplin, please.
Yes, well, thanks very much. It's a pleasure to be here to discuss this issue. You know, the success of the CD19-directed CAR T cells for lymphomas has really energized a new field, even maybe a new modality of treatment of cancer. And there's enormous enthusiasm that this may apply to other diseases, particularly hematologic malignancies, such as multiple myeloma, another B-cell malignancy, that this could be potentially very successful. The chimeric antigen receptors can redirect specificity of T cells away from their native antigen now to the target antigen of the tumor, and can be a specific immunotherapy against those diseases. And hopefully myeloma would be a successful target for such an approach. So you're all aware of the CAR T cell idea. You take the monoclonal antibody antigen binding domain, and you link this to a T cell receptor that then mediates the T cell activation signal to the T cell to kill whatever cell that you have bound with the antibody. And there are first generation CAR T cells that just had this native construct, and then second and third generation CAR T cells where you've added a co-stimulatory molecule such as CD28 or CD137 or combinations of the two. And that these second generation CAR T cells are being currently studied in the fields of lymphoma. So the high rates of responses that we've seen in particularly ALL has led to enthusiasm for this approach, but we also have to note that this is not at the price of, or rather that it comes at the price of some substantial toxicities, where there's a high rate of cytokine release syndrome and neurotoxicity seen with the CD19 specific CAR T cells, and we have to be concerned that we're going to see that type of toxicity, potentially not the CNS disease, but the cytokine syndrome with other CAR T cell approaches in different diseases. Now, one of the other things is that in successful patients with the CD19 CARs, you ablate all B cells, the normal B cells as well as the malignant ones. And in this case, we can accept living without B cells with the intravenous immunoglobulin. But as we think of other diseases, we can't eradicate the normal counterpart for many malignancies. But in myeloma, it would be much like B-cell lymphomas. We could live without, again, the normal plasma cells. And again, suggesting that this might be a viable strategy for treating myeloma. Now, what would be the target antigen that we could go after? Well, we need a target antigen that's present on the clonogenic malignant cells that are capable of sustaining the disease. So if we eradicate those diseases, hopefully we would cure the patients. And again, we need to retain critical normal cells that I just discussed. And there are a number of candidate antigens now for myeloma that we might consider. We might even consider CD19. It's not present on plasma cells, but it might be expressed on myeloma stem cells, and I'll come back to that. So Dr. Manasan just talked about monoclonal antibodies that have been developed that can react against cells from myeloma. So indeed, we have the working parts, if you will, to create a CAR T cell by taking the antigen binding domain of some of these antibodies and using them to construct a CAR. And in fact, this has been done for a variety of potential targets. And we'll discuss the BCMA approach that Dr. Manasan briefly discussed. But one could also target CD38, CD138, and CS1. NY-ESO-1 has also been targeted, as has the kappa light chain. and CD19. And so all these targets are being addressed in different clinical trials currently around the world, most still in a very early stage of development and conduct. So the one question in myeloma is, if we eradicate the plasma cells, will we also eradicate the myeloma stem cells? So there is debate on the relevant role of such cells. Are there memory B cells that are CD19 positive but negative for the mature plasma cell markers that might also be important to eradicate? And will this limit the use of targeted therapies that target only plasma cells? So this is still an open issue, but there are some studies that would suggest that this might be relevant. Now, there's one interesting one from Carl June's group that was published in the New England Journal of Medicine, where there was a patient who had myeloma that was resistant to standard treatments and didn't respond even to an autologous stem cell transplant. But the patient got a second transplant with melphalan 140 milligrams per meter squared, and then the CD19-directed CAR T cell, and that patient achieved a durable complete remission. Now, this is one patient and not necessarily going to be characteristic of all other patients with myeloma, but it did suggest in this situation that eradication of this potential myeloma stem cell compartment might in fact allow one to achieve a durable remission if it's in combination with other treatments that could eradicate the mature plasma cell related disease. Well, the biggest experience so far has been with the BCMA-directed CAR T cells. It's a B-cell maturation antigen. And this was presented by Abbas Ali and Jim Korkendorfer, and it's been published in Blood and presented at the last ASH meeting. And in that study, he showed that there was a dose-dependent activity of these CAR T cells against myeloma, but you required higher doses to begin to see the response. And there was only one of 12 patients that had a dramatic remission, a stringent CR, and one other patient with a partial response. Now, they also noted that toxicity occurred, particularly the cytokine release syndrome, and that responding patients generally did have fever or other symptoms related to that. But it can, and the one patient had a very dramatic response. Here's the patient with multiple areas of skeletal disease before and 2 weeks after treatment, showing very rapid clearance of the myeloma in this patient and a drop of their paraprotein. So clearly there is promise, there's activity here. One will need to see in larger studies just how prevalent that activity will be and whether this really will emerge as a viable treatment. This is the same patient where you could show their disease present before treatment was eradicated when in studies afterwards. And again, the patient has achieved a complete remission. They saw that the level of CAR T cells that was achieved in the blood was associated with the response. This is generally true in lymphoma as well. You need to have the cells be present. They need to survive for a long duration to be able to mediate their therapeutic effects. This slide's hard to see, but shows you the dose response that they started with a low dose, 3 × 10⁶ T cells per kilogram. Didn't see any responses up until the point where they got up to 9 × 10⁶. So 0.3 was the starting dose, and so a 1.5 log greater number was required to see responses in those patients. And again, you see more toxicity with the higher level of responses. There have been other studies now looking at other targets, NY-ESO-1 specific TCRs have been studied. And here they were given in the context of an autologous transplant. And this is where we also have encouraging, at least concepts, that we may be to eradicate the minimal residual disease that causes relapse of the patients. So the patients got their stem cells collected, got their standard autologous transplant with melphalan, and the stem cell infusion. And then the NY-ESO-1 T cells were given immediately afterward during the period of time of lymphodepletion. The high-dose therapy, again, eradicates the lymphocytes. Cytokines are upregulated that then lead to expansion of the engineered T cells and allowing them to hopefully mediate their beneficial effects. And they saw indeed in these patients that they had prolonged remissions. Again, this certainly needs to undergo more definitive testing in a controlled setting. So the next area I wanted to get into is NK cells. We talked about this briefly yesterday in the context of myeloid leukemias, but NK cells are also effective for multiple myeloma. And myeloma cell lines appear very susceptible to NK cell-mediated cytotoxicity. Infusion of NK cells into murine models of myeloma can prolong their survival, and we can see that in a dose-dependent fashion. And we've developed a system at MD Anderson for ex vivo expansion of NK cells that can kill the myeloma in murine models, and now we've taken those into human clinical trials. And this is actually the work of Nina Shah, who developed the expansion system, as well as conducted these trials. So here you can see the pictures. Here's the control mice that have progressive myeloma, and you can see that myeloma is suppressed and delayed in its growth by the infusion of human natural killer cells. So the rationale of NK cells that we're using is that we can use our cord blood bank to identify HLA-compatible NK cells that actually have cure-ligand mismatch to mediate maximal NK cell cytotoxicity. Those human NK cells do not mediate graft versus host disease, so we can give allogeneic NK cells to patients with myeloma and hopefully mediate an anti-tumor effect, and that we can use these as an off-the-shelf source of NK cells that could be used for patients as they present. We don't need to collect the patient's own autologous cells and manipulate them as one has to do with CAR T cells. We can have these cells ready and immediately available for therapeutic use. So the cord blood bank provides us with an enormous resource here where we can select cells that are genetically optimal for each patient. We can use our ex vivo expansion system to expand them 10,000-fold and then give those cells therapeutically. So the system involves co-cultivation of the cord blood cells with an antigen-presenting cell line that does all the co-stimulatory molecules and interleukin-21 that then leads to dramatic expansion of the NK cells, again, a 4-log order expansion, allowing us to give up to 1 × 10⁸ NK cells per kilogram. Again, we have studied these cells in preclinical models, again shown that they retard the growth of myeloma, and have now taken them into a human clinical trial led by Dr. Shah, where we give the patient's high-dose melphalan and an autologous stem cell transplant. We also use low-dose lenalidomide that has been shown to augment the cytotoxicity of NK cells, and then we administer the cord blood NK cells right after the chemotherapy and actually before the autologous transplant. So our biggest worry was if we give these third-party allogeneic NK cells, they may well kill the myeloma, but they could also kill the transplant and cause rejection of the transplant. But fortunately, that has not been seen, and we've treated approximately 40 patients now without seeing any sign of myelosuppression of the transplant. We've done a phase 1 study going all the way up to 10 to the 8th cells per kilogram. We were watching for a lot of potential NK cell-mediated toxicities, but we actually have not seen any toxicities that we would ascribe to the NK cells. Again, we've gone from 5 × 10⁶ up to 10 to the 8th cells per kilogram. We've shown that the NK cell product has expanded NK cells and activated NK cells that are readily cytotoxic against NK cell sensitive and sensitive cell lines and myeloma cell lines, and that the NK cells mediate produce cytokines that are necessary for their activity, as well as directly lyse the myeloma cell lines and fresh myeloma cells. So again, we've seen no infusional toxicities. We've had no graft versus host disease. We had one patient that had graft failure related to a poor product that was collected from an outside source, and that patient was rescued with a backup graft. So again, in up to 40 patients now, we have not seen myelosuppression as a toxicity where that was our major concern. In terms of clinical outcomes of the first 12 patients, we've seen that not 10 of the 12 had high-risk features, including some as second transplants. The median follow-up time at the time of this analysis was 16 months. 9 achieved a VGPR or better, and 4 became MRD negative by flow cytometry, and 11 then went on to receive maintenance therapy. So again, in a phase 1 study, we really can't assess efficacy, but our initial response duration was encouraging, and in that only 4 of the 12 patients have had progression of disease at this point. So we're encouraged to take this forward into more definitive testing. One of the things that we wanted to be sure that the NK cells would survive at least a meaningful period of time, and we can still see the NK cells by day 21. This is an example where the patient was BW6 negative and the cord blood was BW6 positive, and we can see the BW6 positive NK cells as late as 3 weeks after the transplant in the peripheral blood. The cells are active. They express KIR and activation markers of the NK cells, so they regenerate NK cell activity much more rapidly than the natural or autologous stem cell transplant would, and hopefully then can mediate early anti-tumor effects. So our conclusions are that cord blood is a viable source of NK cells for cell therapy. Clinically relevant doses can be generated now with the ex vivo expansion, where we cannot get adequate NK cells from a simple apheresis from a normal donor. Here we can get 100 times more by the ex vivo expansion system. Those cells are well tolerated and seem to mediate important biologic effects. Now, how can we make that even better? We're going to weaponize the NK cells by adding a chimeric antigen receptor. Much like the CAR T cells, we can now make a CAR NK cell, and we can then target both myeloma as well as other hematological malignancies by this strategy. This is being done by Katie Rezvani. And the CAR NK cells, again, have the advantage of not causing graft versus host disease, and we can use our allogeneic CAR NK cells as an off-the-shelf source of cellular immunotherapy, and we're rapidly getting ready to take this into the clinic. So with that, I'll close. I'm happy to answer any questions. Again, this is the work of many people within our group. Nina Shah this is her slide, so she's not on the list, but she was an important contributor to all these studies. Thank you.
Okay, thank you very much. This topic is open for question and comment. Any question?
The audience is exhausted. Perhaps Dr. Parmar can ask a question.
Great presentation, Dr. Champlin. My quick question to you is that, what about the durability of response for the CAR T cells in myeloma? Because the paper that you showed, the very first one from New England Journal, that was after the second transplant, and the other one, I think the follow-up was also short. So in your opinion, do you think that especially in a disease like myeloma, which is a chronic disease, they may need multiple infusions, or what do you think would be the future?
Yeah, so that's one of the issues with CAR T cells in general. One needs to see prolonged survival of the CAR T cell to mediate the anti-tumor effect. So one of the things with the NK cells, they have a naturally shorter half-life or survival time. They only survive a few weeks after the transplant. But if we can introduce IL-15 into the NK cell, and we've done this in the vector that we're using to create the CAR NK cells, that IL-15 will sustain those cells over time and would lead to their prolonged survival. So that's a component of the cell that we're going to be producing for clinical trials. Now, what's the concern about that? Well, could those IL-15 responding cells become transformed, or could they produce other toxicities? So we're also building in a suicide gene, inducible caspase-9. So this is a caspase-9 variant that is naturally inactive, but can activate it if you give a dimerizing drug called AP1903. It's a non-toxic agent that doesn't do anything other than dimerize this inducible caspase-9. It then leads to activation of the caspase-9 and suicide of the cells. So we modify the CAR-NK cells to include this inducible caspase-9, and we can then eliminate those cells if they produce cytokine syndrome or if they produce excessive toxicity. So we think it's an important safety factor that we can build into our cell therapy. We hope it's going to eliminate the problem of the cytokine release syndrome and potentially other toxicities. Thanks.
Okay, thank you very much. Thank you. So, the next speaker is Dr. Jin Lu. She is a Chief Myeloma Professor of Medicine and Hematology, Peking University People's Hospital. She will talk about management of non-secretory myeloma. Dr. Lu, please.
I'm sorry, Dr. Jin Liu cannot come here because of some problem of visa. My name is Shen Miaoyang. I come from the same Institute of Hematology, Peking University. Today I will give the talk instead of her. First, let's start with the criteria for an NSMM, non-secretory multiple myeloma. It is published in 2013, it's a clinician's guide. As unknown, there's two same items as the secretory multiple myeloma, biopsy-proven clonal plasma cells, and the evidence of CRAB symptoms. But we can see for an SMM, we cannot find any evidence of secretory proteins, even by SPEP, UPEP, and also the free light chain measurement. According to the different criteria, the incidence of NSMM is different. In early reports, we can see it constitutes about 3% to 5% of total multiple myeloma, according to the criteria of the negative finding via SPEP and UPEP. Recently, we have the SFLC assays as our routine practice, so the incidence decreased as to lower than 1% to 2%. And in 2014, it's published a profile of multiple myeloma in Asia. It's included 3,405 patients from 7 countries in Asia. And they're reported 1.9% of the total multiple myeloma is non-secretory. So here comes the mechanism of non-secretory multiple myeloma. It's the schematic published this year. There are some steps of immunoglobulin production and secretion. Any errors occurs at any step will finally cause the negative secretory. Let's have some cautions about step 2. If the protein has inappropriate folding, the protein will be degraded into the proteasome. Just now, Professor Orlovsky gave us a very clear the image about how proteasome works. Post the protein assembly and modification, it will be transported to the membrane in the vessels. If there any errors occurs in the assembly and the modification steps, the protein will not be enwrapped. So we cannot detect any protein with UPEP, SPEP, and FLC assays. So here's the subclassification of non-secretory multiple myeloma. This flow chart can give us a clear method to diagnose as NSMM. Here, after the SPEP and UPEP and the SFLC assays, we can have some suspected NSMM patients. Then it's better to do the IgG detect in the cytoplasm, because we can divide this population into the non-secretors and the non-producers. And for the non-secretors, we have also some specific entities, such as the monoclonal gammopathy of kidney significance. That means we can have some pathological evidence in the renal. We can find the monoclonal globulin deposit in the kidney. So that kind of NSM is, the fourth non-secretors. And we also have some differential diagnosis maybe should be caused. The first one is the oligosecretory multiple myeloma with very lower level of paraprotein or light chain. We can detect it in the serum, and the line chain escape phenomenon sometimes happened after the treatment, and it's a kind of clonal evolution, and seldom we can find the dedifferentiated multiple myeloma in our practice. It often happened in the disease progression, and we cannot find any evidence of paraprotein. That means the patient may have big problem. Maybe it becomes a refractory disease. So here comes the workup of suspected NSMM with the practice of SPEP, UPEP, and SFLC analysis. And then we just do our routine about flow cytometry. Maybe we can use flow to measure the intracellular Ig as the immunostaining. And also the CD133 enriched fish to do the chromosome analysis, and also the end organ damage detections. Without the secretory immunoglobulin, we have the problem in the monitoring the response. Maybe here we can only use the bone marrow study and the imaging to evaluate, assess the response. Until now, the serial bone marrow studies is still the gold standard, but it also have some disadvantages because, as we know, MM cells are sometimes patchy and not inconstant, can be detected in the bone marrow. And it's hard to accept it by patients to do serial bone marrow every 6 or 3 months, just like that. Also, the radiological findings, as we know, MRI and the PET-CT scan can be more sensitive than conventional X-ray detection. But recently, some reports demonstrated MRI has inadequate sensitivity for detecting response. So here, maybe we can have the PET-CT scan as the main method to do the monitoring. In the here about the prognostic of the secretory immunoglobulin. In early studies, we can see the non-secretors seems to have favorable prognostic. It's published recently about the Mayo Clinic multiple myeloma database. We can see the stringent defined NSMM patients has really very good outcomes, almost 100% survival. Then those has abnormal FLC ratios. And where comes the advantage of this type of multiple myeloma? We just consider there are some reasons. First is the renal insufficiency is uncommon, but in recent database we cannot see it. We cannot see this result. Sometimes the similar incidence of renal insufficiency was reported. So the second one is in preliminary studies, NSMM might express line chains on class 1 MHC receptors, which can stimulate anti-NSM CTL responses. And the third one is it's reported there's more patients have translocation 11 and 14 chromosome aberrations. As of now, it's a standard risk karyotype aberration. But more reports said the co-occurrence of other chromosome aberrations, such as TP53 or others, made difficulties to understand what's the prognosis about this chromosomal aberration. And final one is the differential response to therapy. Here comes from the Mayo Clinic's database. Before 2001, we can see there's no difference between the non-secretory and the secretory multiple myeloma. And in 2001 to 2012, we can see a better outcome of those NSMM patients. So we cannot stop thinking it comes from the novel agents. Here, also the Mayo's database showed us the novel agents brings the benefit to those patients. If patients can achieve CR with initial therapy, they would have a trend to have good prognosis. Here, let's review this schematic, the step 2A, the proteasome here, if any inappropriate folding protein would be degraded into the proteasome. So we just postulate proteasome inhibitors may be bring more benefit to this kind of patients. So we also considered ASCT might bring benefit for those patients in this modern era. But in Mayo's database and the CIBMTR database, we just can only conclude ASCT brings the same benefit to NSM patients as the SMM. So here just a summary. NSM patients is really very rare, and the biology is incomplete understood until now. And with more sensitive techniques to detect immunoglobulin secretion, the incidence will be decreased. And now we have the big challenge to monitoring the response of these rare patients. And maybe the novel agents can bring more benefit for those patients. Okay, thank you.
Thank you very much. This topic is open for question or comment.
Thank you, Dr. Yang. I'm sorry, I may have missed it, but in your center, how are you monitoring these non-secretory myelomas? Do you do marrow? Do you do PET scans? Do you do both? Do you do bone scans? What do you think would be optimal for this disease?
Thank you. Thank you for the question. In our institute, we just use the serial bone marrow biopsy and the aspiration. We just try to find some pan-tumor biomarkers to detect to do the MRD detection for the multiple myeloma patients. Professor Liu has already published some articles about some molecules such as the WT1 and the other molecule, I'm sorry, and also the next generation sequencing is on study, and we just consider that flow cytometry will be a very strong method to detect the MRD, and the PET-CT scan is very important method to detect MRD in these patients, because in our experience, NSMM patients have a big problem in their bone lesions. Sometimes they will come to us with very serious bone lesions and the symptoms. So the PET-CT is the main method in our institute to evaluate. Yeah.
What is your experience with the oligosecretory myeloma? Because that probably is more common than non-secretory, and we see patients with very extensive disease but very little light chain expressions. Do you have this? What is your experience in this group of patients? And their response, is it better than the others who are fully secretory?
So you mean the
Oligo.
Oligosecretory? Yeah, yeah. With the oligo multiple myeloma, yeah, I don't have too much experience about that. Yes, I think according to the very little expression of immunoglobulin and the line chain, we really have the problem to assessing the response. But till now, I don't think there's a big difference of the treatment and the observation of the long-term outcome of these patients. Okay, thank you.
I just have a suggestion for you. When you put your data together looking at proteasome inhibitors in non-secretory myeloma, what you should try to do, if you can, is go back to the bone marrows, because there's going to be two types of non-secretory patients. There's going to be the patients who make light chains, but they stay intracellular and are not excreted or secreted. And then there's going to be patients who make no light chains. And I would predict that the bortezomib sensitivity will be greater among the people who make light chains but don't secrete them versus the people who make no light chains whatsoever. And that may be something you can look at by immunohistochemistry or by PCR, looking at whether the light chains are expressed or not.
Okay, thank you.
Okay, thank you very much.
Okay.
So come to the last topic of this session is the management of bone disease in myeloma. Please welcome Dr. Robert Orlovsky. Please.
All right, thanks very much. I have good news for you, and I have bad news for you. The good news is that this is the last talk of the session and the last time you'll hear from me at this session. The bad news is it's not the last time you'll hear from me during the meeting, because I'm also giving the lunch symposium, so just thought I'd give you a warning. But I was asked to talk about myeloma bone disease, and this is a very complex interaction between myeloma cells and the bone marrow microenvironment, and really is a combination of two main factors. First of all, you have osteoclast activation, which is a result of the myeloma cell interacting with the cellular microenvironment. And also you have osteoblast suppression, and that makes it a complicated scenario because probably no one drug by itself is going to be enough to reverse bone disease in myeloma. But let's look a little bit at the history. Of course, bisphosphonates have been around for a long time, and whether you look at pamidronate or zoledronic acid or some of the oral bisphosphonates that are around, many studies have been done. The majority that were done in a phase 3 setting do show that there is a reduction in the incidence of skeletal-related events when you use bisphosphonates in patients with myeloma. As a result of these and other studies, there have been a number of different guidelines that were put out for the use of bisphosphonates in myeloma. This one is from ASCO, which is from 2007, and they recommended giving these drugs to patients that had either lytic disease or compression fractures or osteoporosis that was out of proportion for their age. And the recommendation was to give either 90 milligrams of pamidronate or 4 milligrams of zoledronic acid every 3 to 4 weeks for a duration of 24 months, although if they had gotten a tandem transplant and were in complete remission, you could consider stopping them at 1 year. And there was the proviso that you could restart therapy if there was progression or a new skeletal-related event. Of course, with bisphosphonates, there are recommendations to make sure that you have patients get a good dental exam because of the risk of jaw osteonecrosis, which seems to be increased if you have some kind of infectious process. Because renal insufficiency is a long-term risk with many bisphosphonates, you should monitor creatinine levels as well as calcium, electrolytes, and so forth. And it may be useful to check for albuminuria every 3 to 6 months because a new or rising albuminuria is often a precursor to bisphosphonate-related renal insufficiency. One of the limitations of bisphosphonates is that, at least with the drugs that we have predominantly used, which are zoledronic acid and pamidronate, they are not recommended for use in patients that have severe renal insufficiency with creatinine clearances less than 30. And there are some recommendations, as you can see, for either reduced dosing if you have less severe renal insufficiency, for example, a reduction in the dose of zoledronic acid, or that you consider a longer IV infusion, for example, with pamidronate. Newer guidelines have gone a little bit further and now say, for example, from the International Myeloma Working Group, that these drugs should be given for all patients with myeloma, whether they have bone disease or not. And the rationale is in part based on sub-analyses of the previous studies, which I showed you, that did determine that there was a lower risk of skeletal-related events, even in patients that did not have bone lesions at baseline. And the NCCN recommendations also say now that use of bisphosphonates is a Category 1 recommendation for active myeloma, although not yet a Category 1 recommendation for smoldering myeloma, and also recommend monitoring renal function and a good dental exam. Where things kind of got a little bit interesting is from, for example, the MRC9 study, where there was a suggestion that maybe bisphosphonates could have an impact not just on bone disease, but on clinical outcomes. You remember probably this was quite a large study where patients were randomized to receive intensive or non-intensive induction, but there also was a randomization to oral clodronate versus IV zoledronic acid. And you can see from this initial analysis published a few years ago that it looked like the group that got zoledronic acid had a slight improvement in progression-free survival as well as overall survival. And the most recent update that we have is from 2013. Here, the progression-free survival was only different by about 1 month, but because this was such a large study, the p-value, as you see above, was still considered significant. And these are the overall survival data, which interestingly have a bigger difference with a 6-month difference in overall survival, which again was considered statistically significant. And this one you would probably consider to be clinically significant as well, because I think a 1-month PFS you could argue about, but if you really get a 6-month improvement in survival, that's quite nice. The problem is in those studies, of course, everybody got zoledronic acid or clodronate in a manner that was not determined by biomarkers. And we do have some biomarkers that can help us to determine how much bone turnover is occurring. So recently, Nupur Raj published the result of the so-called ZMARK study. This was not necessarily a randomized study, but what they looked at is the UNTX level. And if you had a high level, you received therapy with zoledronic acid every 4 weeks, whereas if you had a low level, you were randomized to receive it every 12 weeks. Now, the problem is you can see only 4 patients were in the group that had the high level, so it's tough to make a lot of conclusions. And most of the 4 actually wound up crossing over to the every 12-week dosing, because after zoledronic acid was started, their levels dropped, whereas there were some patients who crossed over from the every 12 to the every 4 because of disease progression. The results on this study show that the overall skeletal-related event rate was low during both years 1 and 2, and so their tentative conclusion was that it would be probably safe to give Q12-week zoledronic acid instead of Q4-week, but again, remember, not a formal randomized study. Now, fortunately, just this year, there was a paper published in JAMA which did a randomized study, and they took almost 1,900 patients, of whom 278 were myeloma patients, and randomized them to every 4-week versus every 12-week therapy. And this was not using any kind of biomarker. This was a straight randomization. And you can see that the curves are very close to each other and no significant statistical difference between them. And if anything, because the y-axis is skeletal-related events or death, the every 4-week dosing actually had a small trend to more skeletal-related events. Again, though, not statistically significant. Now, if you pull out just the myeloma patients in this study, you can see that there were 139 patients that were randomized to either every 4-week or every 12-week dosing, and there was no difference in the skeletal-related events. So not quite as good as randomizing 1,000 myeloma patients, But still, the data do suggest that every 12-week dosing is certainly very reasonable from this trial. And interestingly here, if you look at what happened to some of these markers, like the mean C-telepeptide level, what you can see is that the Q12-week dosing actually didn't suppress the levels as much as the Q4-week dosing, and yet it didn't make a difference in terms of bone events. And so that suggests that maybe looking at one biomarker is not enough, and we need either to get better biomarkers or maybe we need to look at a combination of them. More recently, there's been interest in looking at denosumab. Denosumab is a rank ligand inhibitor and was looked at in a number of studies, but here's a phase 3 trial of almost 1,800 patients, which concluded that denosumab was actually superior to zoledronic acid. Adverse event-wise, there was a lower risk of anemia, fever, acute reactions, and hypocalcemia, and a greater suppression of urinary and telepeptide levels, as well as a trend towards less anorexia and renal adverse events, while ONJ and increased creatinine, you can see the numbers, so not significantly different. The problem was that when they looked at the myeloma cohort in this group, they were limited to 10% of the study, and although the skeletal-related event hazard ratio was roughly equivalent for myeloma, a survival analysis actually showed that the patients who got zoledronic acid had much better survival than the people who got denosumab. So that led to the approval of denosumab for all other malignancies, but not myeloma. Interestingly, when the myeloma data were looked at in more detail, this was an interesting curve. You can see percentage of patients that were surviving, and the zoledronic acid curve appears to have a plateau during which patients seem to be surviving fine, whereas the denosumab curve is dropping down. And it turned out that the way that this study was designed is that patients who withdrew consent from the study were no longer followed for survival. And for whatever reason, people on zoledronic acid withdrew more often, and therefore it looked like they were surviving better, but in fact the reason was they were not being followed as closely. And when the curves were redrawn, it actually turned out that they were much closer together, suggesting that there was no survival benefit for zoledronic acid over denosumab. And although we don't have the data yet, just before ASH, there was a press release from Amgen about the 482 study. This was a gold standard study which took 1,700 patients with myeloma, randomized them to sub-Q denosumab with IV placebo or IV zoledronic acid with sub-Q placebo. So this was a randomized double-blind study, and the report is that time to first study skeletal-related events was the primary endpoint, and you can see that the primary endpoint was met, meaning that denosumab was not inferior, and therefore the hazard ratio looks pretty good, and hopefully this will lead to approval of denosumab for myeloma as well. Now, there are other bone disease mediators than rank ligand. As I showed you in that first slide, this is still a challenge. Here is a list of just some of the important cytokines that are involved in increasing bone absorption, as well as some that are involved in osteoblast activity inhibition. So you can see rank ligand is just one of many that are involved here, which is why even on zoledronic acid and even on denosumab, patients with myeloma still develop bone disease. So we clearly need to do more for them. I did think I would highlight one new factor that actually Jing Yang at MD Anderson found. She's a scientist who focuses on myeloma bone disease and just published a paper in Science Translational Medicine about the role of thymidine phosphorylase. She found that this was highly expressed in myeloma cells compared to normal plasma cells, and you can see that in the top panel. And high expression was associated with increased bone destruction. So if you look at the lower panel on the left, you can see a bone chip in an animal with no myeloma. The one in the middle is a bone chip with myeloma that expresses high levels of thymidine phosphorylase, and you can see all of the destruction going on, whereas on the right is a low level of expression where there's some bone disease, but not quite as much. And this also has some therapeutic implications because she was able to show that clinically relevant thymidine phosphorylase inhibitors that are already in patients with cancer for other reasons reduced bone disease. So again, if you look at the left photo, you can see bone disease in the presence of myeloma with vehicle, whereas the middle and the right panels show the amount of bone disease when you have a thymidine phosphorylase inhibitor present. So this could be something to look at in the future in combination with other drugs. And her model, which was published in this paper, showed that thymidine phosphorylase has an impact on a number of downstream mediators of bone activity, including RUNX2, Austerix, and IRF8. It's also important to remember that not just bone-targeted agents, but chemotherapeutics can have a positive impact on bone biology, and we know from a number of studies that I won't review for you that proteasome inhibitors in particular are very helpful in terms of bone biology and inhibit rank ligand as well as osteoclasts. Also, when talking about bone disease, it's important to remember that compression fractures can be treated in a number of fashions, including with vertebroplasty or kyphoplasty. And we have a randomized study published a few years ago by Jim Berenson, who's been one of the leaders in studying bone disease clinically, that shows that balloon kyphoplasty is superior to just supportive care in terms of severe pain management and also in the ability of patients to return to a good functional status. So I think the conclusions I can leave you with are that for right now, zoledronic acid still is the standard of care for myeloma patients and probably for all myeloma patients, whether they have bone disease or not. Less frequent dosing, though, seems to be very reasonable, giving it every 12 weeks, which should further reduce the risk of osteonecrosis as well as renal insufficiency. And especially less frequent dosing is reasonable if there are low levels of N-telepeptide. As I showed you, denosumab may soon be an option and could have a better side effect profile in some regards, although osteonecrosis remains an issue. And it's also important that you also hit the myeloma with the optimal chemotherapy, including proteasome inhibitors, because the best way to support bone health is by killing off as much of the myeloma as you can. But as I mentioned, challenges do remain. 85% of patients still develop bone disease, and so additional therapeutics are needed. And the question is whether there's one combination of drugs that is best for everybody, or can we use biomarkers to identify patients who need more therapy? For example, if you have low N-telepeptide levels on a bisphosphonate, maybe you're good, whereas if they're still high, maybe you need a bisphosphonate with something else. And this is something where, as you saw, we need thousands of myeloma patients for these studies, and therefore, hopefully, we can all cooperate to work out what is the best combination for everyone. And thanks very much. I'm happy to take any bony questions.
Okay, thank you very much.
Yeah, I've had two patients that didn't have myeloma that we gave denosumab to, and they both had profound hypocalcemia and a lot of problems related to that. I'm just wondering how much problems you see in your practice.
Yeah, definitely. So hypocalcemia is one of the risks with denosumab, probably more so than is the case with zoledronic acid, although sometimes you can see it there. And there is a recommendation to keep patients on calcium repletion if that's going to be used. So definitely an issue, one of the downsides to the drug.
So if there is no question, thank you very much.
Right,
Okay,
thank you.
I think that concludes this session. I would like to thank all the speakers and all the participants of this session. Thank you.